Greetings, everyone. This is Eric Glazer, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform you, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations across the land. Our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe this approach of finding a bright spot and cloning it is the most effective way to improving healthcare in our lifetime. And this is a really interesting episode. We're going to cover a range of topics. Our guest today is Robert Andrews. He's the Chief Executive Officer at Health Transformation Alliance. He served 2 years prior to HTA, where he had a brief stint at a law firm. He served as the member of the United States House of Representatives, representing the great state of New Jersey for 24 years. On his departure from Congress, President Barack Obama praised Andrews' service as the original voice, this is quote, the original voice of the Affordable Health Care Act, and a vital partner in its passage and implementation. He cited his tenacity and skill in representing the people of New Jersey. As CEO of the HTA, Andrew oversees the strategic direction of approximately 60 plus major corporations that have come together in an alliance to do one thing, and that is fix the broken healthcare system. So, Robert, thank you very much for taking the time to be with me on the Bright Spot Show.
Eric, thanks for citing the bright spot. I am allergic to restating the problems of healthcare ad nauseum. And I think you're performing a great service by focusing on people who are trying to solve problems and have some solutions. And what a great contribution you make.
Oh, thank you. Thank you for saying that. I appreciate that. Before we dive into bright spots, I know that HTA was formed in September 2015 by 4 founding corporations, members, as you call them. And today, the association has 66 member companies, collectively responsible for 8 million employees, dependents, and retirees across the globe, 5 million of them in the U.S. And those organizations in their entirety spend over $30 billion on healthcare. So I'd love just to set the framework for our discussion. You tell us a little bit more about HTA than I'm able to, and then we'll jump into some questions that may enlighten our audience around bright spots that are happening around the country.
HTA founders really fit the DNA of Bright Spot. Tired of hearing the problems restated, eager to try to come together and find some solutions. So American Express, Macy's, Verizon, Caterpillar came together in the fall of 15 and said, look, we spend a lot of money. We have a lot of data. We have a shared conclusion that we're not getting the value we should for our spend. Let's not focus on beating up whoever's fault we think it is or lobbying the Congress to try to fix it. Let's try to fix it. Let's put our dollars behind care that is high value. Let's not look for the cheapest spinal fusion. Let's look for the provider who can make someone's back feel better, whether it's through physical therapy or a great spinal fusion operation. But let's focus on making people healthier. And let's leave our, ideological and business baggage at the door. So out of that was formed the HTA. Here we are nearly 8 years later, and much stronger, much larger, and learning, Eric, every day how much we don't know. We by no means hold ourselves out as some paragon of easy solutions. But what we do know is if you follow the data, if you use the classic Aristotelian model of trial and error, find what works, you find things that do. And when you do, we try to spread them throughout the healthcare economy.
It sounds, I'm super interested to hear more about what this organization is able to do. I know it is not easy to form alliances amongst independent corporations like that who are working with their own inherent business challenges on a quarterly basis. And so, and I know a lot of like organizations have been less than effective over our history. So I'm excited to hear more about it. I'm sure our audience is too. Let's start with pharmaceuticals and medication management. I know there's all different directions we could go into that category, but I'd love to just allow you to talk a bit about how we best support employees, we'll call them consumers, around pharmaceuticals, especially when they have multiple providers prescribing drugs in different sort of silos, and what you're doing to mitigate, and what your group is doing to sort of mitigate those costs, those risks associated with less than optimal quality of care.
Well, here's what we've learned about that question, Eric. What we've learned not to do is to discount the incredible stress that someone's under when they're on one of these expensive specialty drugs. By definition, this is someone with cancer or multiple sclerosis or late-stage renal failure. These are really sick, stressed people. And any employer who approaches that family and says, we're going to find the cheapest way to take care of you, is a failure by definition, because that's not the objective. The objective is to find the optimal result, to take the best care of that person. And what we found in trying to reach that objective of easing the burden on someone who's that sick is you want to ask a couple of really important questions. How many sets of clinically competent eyes have looked at the drug this person is on and where they're getting it and what it's for? And sometimes the answer is too many. And this is in no way to impugn or criticize the many specialists who touch that patient. But the nephrologist is focused on the kidney, and the cardiologist is focused on the heart and the circulatory system. And there might be a neurologist who's involved focusing on stroke risks. And the general practitioner is involved in sort of everything. They don't always communicate with each other in a coherent way, not because they're not competent, the opposite is true. Not because they don't care, almost always the opposite is true. But it's because they all have their swim lane that they're stroking away in. What we found is if you look at a family that's going through that crisis and you put them in touch with clinically competent people, usually starting with a pharmacist, who looks at the drugs that they're on and asks the question, look, is this right? Is this the right path for the person to be on? Most of the time, by the way, the answer is yes, it is. And our members pay those costs and hopefully make people better. But a fairly significant part of the time, the answer is no, it isn't. That maybe the person's on the wrong drug, or they're perhaps receiving the drug at the wrong venue, because where the drug is administered, particularly with infusibles, which are about 40% of the drugs in this category, where you get the drug is really important. So what we learned is ask those questions and gotten some really compelling answers.
So tell me a little bit about how it works and how this program works, number one. And two, how is it differ from, let's say, what a health plan or a vertically integrated health system health plan may be able to pull off, and why maybe it seems to be working for your members, for your consortium of employers?
It's a lot like what a vertically integrated health system could do, but most people aren't in vertically integrated health systems, right? They've got a Tower of Babel of providers that they're listening to and trying to learn from. So how we're different from that Tower of Babel is that the clinical specialists will look at the health data with the patient's consent of the health data. So one example is there's a mom with 3 boys, and all 3 of the boys are on a very significant growth hormone. The growth hormone has significant side effects. It's very powerful. It costs about $100,000 a year per child. So the little boys are on the hormone for a period of time. The mom then became involved in the program that we support. And the clinician looked at the 3 boys and said, boy number 1 and boy number 2, clearly this is the right path for them. But the third boy's around the 50th percentile in height and weight. Doesn't really appear to be the right therapy for this child to be on a growth hormone. So the clinician interacted with the pediatrician, the other relevant providers, and the parents, and came up with the conclusion that, the right path for this child was to come off the growth hormone. So the child comes off the growth hormone, is no longer subjected to the potential side effects of the growth hormone, and the company paying the bill and the mom and dad helping to pay the bill save $100,000 off that spend, so 33% reduction in their spend. That doesn't happen all that often, Eric, but it is a bright spot. It is what you find when you look for the data and you say, look, none of our employers would want to say, we're trying to take care of your boys who have a growth problem on the cheap. That's not what we do. But we do want to say, is this the right way that these little guys should be taken care of? In this case, the answer was no. And there was a much better clinical result for the family and a significant economic saving for the employer and the family.
So we have a program in place that enables pharmacists to do asynchronous virtual reviews of members who are on specialty medications to ensure if the cocktail of drugs that member has, that consumer has been prescribed is optimal. So do all 60 of your member companies now adopt that program, number one? And two, how does that program integrate in to each individual member company's health plan or ASO?
The only thus far, about 1/10 of our members, maybe a little more, have signed up for this because it's new, it's change, and you have to look very carefully at it. And part of the reason, Eric, is it doesn't always integrate very easily. People in the benefit space call it a carve out. And basically what has to happen here is that decisions about which specialty drugs to buy and how to structure the payment and whatnot are taken away from either the pharmacy benefit manager or the insurance carrier or both. And so that does involve some administrative friction. We're not oblivious to the fact that that's important to a lot of benefit leads. They want to reduce friction, not add to it. The financial results, though, are compelling. Our member companies who've used this program have saved between 30 and 40% year to year on their spend. So a company spending $10 million last year is spending 7.5 or 7 or 6.5 right now. Pretty significant.
Big time. That's big time. I want to get to sort of how anyone listening could begin to think about working with you on programs like this, whether they're a health system plan or even an employer that may be listening. But we'll do that towards the end, folks. Just I want to take a right turn to a new topic and another area that you're looking to tackle, and that is infant mortality, which is especially high in traditionally underserved minority populations. So how is HTA, that doesn't serve necessarily Medicaid per se or Medicare populations, how do they see infant mortality as a problem they're tackling, and how are they going about as a group with a solution?
We see infant mortality as a national tragedy, and we see it. Our employees who are covered, some of them are code writers for big tech companies, but some change bed linens at the Marriott Hotel, or they work at the counter at the Walgreens. We have the full spectrum of economic families, income levels and whatnot. So we care about this for that reason, as well as the greater impact. But like so many other maladies in the American healthcare system, infant mortality has a decided racial and demographic and cultural footprint. Women of color, babies of color are much more likely to be at risk relative to the rest of the population. This is another example, Eric, where we tried to go to what I know is the DNA of bright spots. Most women and most babies of color and lower income groups, or both, don't wind up in the NICU, don't wind up in the ICU. So we tried to focus on the success stories of where a woman is at high risk, a baby's at high risk, you can do something about it. We partnered with Meharry Medical University, a first-rate school in Tennessee that has really spent decades working on this problem. And I don't think you'd be surprised by the answer. There's not some high-tech, high-data, generative AI answer to this. It is culturally competent, compassionate human beings interacting on a regular basis with a woman while she is pregnant or even before she becomes pregnant. It's trust and empathy. And when you put that into the system, you're much more likely to find the mom takes better care of herself. The birth is much more normal, and you reduce the number of preterm births rather significantly. So it's really not a mystery. It's culturally competent, empathetic people interacting with each other.
So what does the program look like that you have in place, and how is it working?
We don't have a program per se. What we try to do is connect the caregiver who's working with a mom who's at risk with people like Mahari that can help share models with them. You know this, Eric. You've dealt with many providers. You do every day. Second guessing providers is a really bad strategy, particularly when you're not competent to do that. Like I would not be competent to do that. I'm not a physician. I'm a dad, but I'm not a physician. So what we try to do here is use the sensible approach of working with the providers that the members of the HTA companies are seeing and making those providers know about the resources we could offer to make available to them.
I just, I rarely cross-promote, but I just had an episode that I did recorded with Angela Thomas, who's the Vice President of Healthcare Delivery Research at MedStar Health, in the MedStar Health Research Institute, which is down in the, down from me in New England, the Baltimore, Maryland area, Washington, D.C. area. So if this is a topic that's important to all of you, I encourage you to go find that episode as well, because we'll get into their Safe Babies, Safe Moms programs, which I'm sure has a lot of different similarities and components and some of the things that Robert Andrews just mentioned, but goes into even more detail. That's super exciting. I think I want to do more programming around in this area as well, especially around prenatal interventions and care. So I applaud you and your members for going after that.
Thank you.
Let's talk now about the population as a whole and population health as a whole, because I think being able to identify consumers who are on less than optimal medication cocktails versus trying to find women who are at higher risk and intervening around infant mortality. These are all things that are relying upon a evolving, more sophisticated approach to population health and analytics. So how are these large companies coming together with you to figure that out? And
first thing companies are trying to do is, without being combative, staking their rightful claim to their data. When American Express or Bank of New York Mellon or Coca-Cola or JP Morgan Chase, all of whom are members, are paying most of the claims of the people who work for them and their families, we certainly respect the HIPAA privacy rights of the consumer. Consumer comes first. But the employer, as the payer, has rights to those data. And within those rights lies the story of who's doing a good job and who isn't. Data tell the story. And sadly, I still think there's a presumption when an employer tries to obtain their data from a carrier or pharmacy benefit manager, they have to kind of beg for it. We're not going to do that. Our employers are acutely aware of the notion that, consistent with their fiduciary obligations under federal law, they not only have the right to have this data, they have the obligation to have this data and take a look at it. Fundamental law here, Eric, and you know it, the ERISA law, is when a health plan spends $1, they have to be able to justify the dollar as well spent and not wasted. How can you do that if you don't have easy access to the data which show who has a high hospital readmission rate and who doesn't? What the high cost provider is versus what the low cost provider is and what the difference is. So our members are adamant that they must have rights to the data, and we've worked together with them in collaboration with carriers and PBMs, sometimes a little tug of war, but in collaboration. And we've assembled a data platform of over 4 million claim lives, going back about 5 years, that has a lot of demographic and other information. That then helps you start to see the bright spots. You can start to see what, so my favorite example of this, which I know you have a mind for too, is looking for the unexpected causal determinant in a data field. So we all sort of know that if somebody's struggling with their weight and sick a lot and their A1C levels rising, they're probably at risk for diabetes. Got it. But what's the unpredictable factor? And my favorite story in our years in analytics has not to do with healthcare, but has to do with one of our members that makes small business loans. And they hired an analytics firm to take a look at who's a good risk to make a small business loan to. And one of the things the analytics firm told them was that if you look and if the income is the same and the wealth is the same and the credit rating is the same for two borrowers, if borrower A has a pet and borrower B doesn't, borrower A is the best bet. That a pet owner is more responsible than someone who's not a pet owner. That's kind of whimsical, but think of the internal logic. It's kind of true, isn't it? It's kind of true. So we look for those pet owners, to coin a phrase, in the healthcare space. What's the unusual predictor that you might find that would lead you to paying closer attention to avoiding someone with diabetes, helping them prevent diabetes or helping them prevent some other kind of problem? Now, these don't fall the sky every day, but they sure are interesting to find, and we spend a lot of time looking at that through this data platform.
Oh, wow, that's like, that is just right in line with the show's mission. I love that. Do they own a pet? By the way, I don't own a pet, so that could hurt my credit.
I immediately ran out, and my wife and I bought 2 rescue cats. Immediately, we heard this. So our credit rating would improve.
So any anecdotal results from this overall initiative that you could share with us?
One will not surprise you, but where we're digging, I think, will excite you. We do think there's a connection between loneliness and behavioral health problems, and therefore chronic health problems. If you're trying to motivate yourself to exercise more, lose weight, eat more carefully, and you're lonely, the internal logic strikes me as that's harder to do than if you have a spouse or a sibling or a son or daughter who's pushing you in that direction. Now, I think that's not new. I noticed your senator from Connecticut, Chris Murphy, is very interested in this topic. I just read an article about him focusing on that this weekend. What we're trying to look for, Eric, is the plan members who live alone, who are maybe lonely, but who still have good health results, who are able to manage their weight or their exercise routine or their diet or what have you. In other words, if loneliness is the yin, then what's the yang? What is the thing that would motivate a person who otherwise might be lonely to achieve the kind of result that you want to achieve? And so much of this, you know this, again, from your career, chronic disease, whether it is diabetes, whether it is obesity, even in many cases cardiology, is so closely tied to behavior, so closely tied to what you eat, whether you exercise, whether you take care of yourself. So we are looking at, maybe it's the Elvis song, Only the Lonely, I can't remember he sang that, but we're looking for the lonely, technically, who've successfully managed prevention of chronic illness.
I love it. Is there any, and maybe there's nothing there, I think it was Roy Orbison, Only the Lonely, just
Roy Orbison, you got it.
Fans out there, we want to serve everyone listening. Was there any connection to dive down in more into the risks of loneliness, and did the pet factor come in there, or was that just a separate, different initiative?
We haven't gotten there yet, trying to figure it out, because believe me, if you could find it, it really might be worth its weight, no pun intended, in gold, where you could persuade the person figure out what this factor is that would move them in the right direction. But look, you know this. If the percentage of Americans who are morbidly obese was the same as it was 2 decades ago, healthcare costs would be 10 or 15% less in the country across the system. Let me say that again. If the share of Americans who are morbidly obese was only as great as it was about 2 decades ago, we'd be saving hundreds of billions of dollars. And the we there would be employers, Medicare, Medicaid, the whole system. Weight is to some extent about genetics. There's no doubt about that, but to a greater extent about behavior. So how do you change that? Don't know. But we sure are interested in looking. And the other place we tend to look for this, which sounds a little whimsical, is outside of healthcare to people like the gaming industry.
Yeah.
The gambling casinos know exactly how many free steak dinners to give you. So you'll spend another $1,000 at the crab tables. They're really good at that cause and effect. Well, if someone can figure that out, maybe they could figure out how a 51-year-old factory worker who lives by himself could get better at managing his diet and his exercise and not have a heart attack. It's worth doing.
So you're speaking my language. I am such a big believer that we need to get out of our echo chamber in healthcare, bring outside industry. And it strikes me as being very validating to hear that your Do They Own a Pet analytics project was discovered by someone who, although they joined the consortium to help with their healthcare, are actually not in the healthcare industry. They're giving out loans. So that's a perfect example of bringing in expertise and trying to see if those bright...
We want to be humble enough to understand what we don't understand. And that means to listen to people who are analytically sharp from outside the healthcare field and ask them to tackle these problems. They're not going to wave some magic wand, Eric. But, the status quo group hasn't done so well on this problem, including me. So I think that we have to be humble enough to look outside the system for that.
Well said, and a great way to sort of put a bow on this conversation. I really just enjoy hearing what this group is trying to do. It certainly sounds like they have the right leader in place. So I really appreciate you sharing with all of us those anecdotes. It's
very happy to do that.
How can organizations, whether they're health plans, providers, other employers, work with HTA or at least get in touch with the organization and get in touch with Congressman Robert Andrews?
I'll give you my email. They're welcome to use it. We don't hide. We'd love to hear from people. It's my name, R. Andrews, ANDREWS, at HTAhealth.com. R. Andrews at HTAhealth.com. That's me. It's not a bot. I'd love to hear from you. Particularly, I really appreciate the Roy Orbison correction there. So anybody who has that sort of deep, trivial knowledge, I would also appreciate.
Or talk a little golf, but mostly healthcare, right? Thank you. Exactly. Thank you so much for taking the time and speaking to our incredible, interested and innovative audience.
Well, again, thank you for piercing through what I would call the endless bog of problem restatement. I've had it with that. Yeah, the next pitch deck that I see that says, we waste 30% of our money in U.S. healthcare, and that 20% of the claimants drive 80% of the cost. And I was like, I got it. Sun rises in east. That I do believe there's a lot of really talented men and women out there who are getting stuff done. We want to meet them. We want to learn from them. And to the extent that we can, we want to direct some of that $30 billion a year that our members spend toward rewarding people who've come up with those kind of solutions.
Wow. You're hired as the next host of Bright Spots in Healthcare.
You got a better one than me.
Thank you so much. A message to all of you listening, to what the Congressman just said. A problem may look hopelessly complex. Rather than looking for the massive cover, rather than lamenting around that massive hole, use the strategy of finding a bright spot. Like, do you have a pet correlating with higher likelihood of getting loans paid? Look for those bright spots among all the chaos, because those are the tactics, those are the little positive deviants, when you identify them and figure out how to scale them, that could be the entire solution strategy to many of your toughest challenges.
How penicillin was discovered, right?
That's right.
It's an accident, a terrific accident.
So, I hope we use some of the bright spots that Robert shared with all of us to inspire your thinking, maybe even do something more than that and clone some of those ideas so that your company's current approach can improve healthcare for all of us. We produce the show for all of you. And as a reminder, this is your Bright Spots in Healthcare podcast. Take care, everyone. Thanks again, Rob.